So it's a real privilege for me to introduce my colleague, Dr. Barry Trachtenberg, who did his internship and residency at Baylor College of Medicine, followed by cardiology fellowship in advanced heart failure training at the University of Miami. Has been part of our program now for several years and has taken the lead in so many ways, including a focus in on cardio-oncology, really bringing the program up from non-existence to working tremendously well. And in addition to that, integral to our efforts related to treating patients with amyloid and infiltrative cardiomyopathies in general. So Barry, we appreciate your participation as always.
Thank you, Jerry. Hope you didn't give away the first case, but it's kind of obvious. So I'm going to present a couple cases just to exemplify some infiltrated cardiomyopathies that we see relatively commonly. So this is a 65-year-old who came to me for a second opinion. He was told that his heart was weak. In 2012, he was first diagnosed with heart failure. 1 year prior to this, he was supposed to go for a colonoscopy, had an abnormal EKG, ended up having an angiogram that was normal or mild non-obstructive disease. He had an AICD placed in 2012. In 2015, he had 2 AICD shocks and has since been on amiodarone and without any AICD firing. His last hospitalization was 6 months prior to my visit for volume overload, currently New York Heart 2 symptoms, additional past medical histories for atrial fibrillation. He had carpal tunnel release in 2005 and 2011, but he said he was an electrician and it was to be expected, and family medical history was unremarkable for any sudden cardiac death. There's his EKG, it's paced, otherwise unremarkable. This is his echo. It's not the best echo, but it's his, and we can see here he has quite a bit of what looks like concentric LVH. If you look at the panel on the right, you see very large atria, almost as big as his ventricles. You can almost make out some right ventricular hypertrophy a little bit better here in the subcostal view. And here you see he has, just looking at his mitral inflow pattern and his tissue Doppler, he has a restricted filling pattern. So which of the following is not an appropriate next test? So I think a lot of people in the audience are thinking about perhaps amyloidosis. So which of these would you think is not the next best test to order? Not necessarily that it's a wrong test or what's not next. And everybody vote. Your vote counts here. I promise you there's no gerrymandering, so please vote. I think we have one person that voted, or maybe 2, 3. Okay, so that's, all right, good. So I think, there's no real wrong answer here. But right now, this patient we think has amyloidosis. We're concerned about it. And we still don't know what type he has. So I think we'll come back to that question in a moment. So we did a cardiac MRI, and it did confirm our suspicion for amyloidosis. Not that it was absolutely necessary to do so, but it did confirm what we thought. And then we ordered a kappa lambda light chain ratio, which tells you the ratio of kappa and lambda light chains, as well as the individual values. And that is looking for AL or systemic amyloidosis, and with a range really under 0.5 or greater than 5 that are highly specific for it. So here he has a pretty normal ratio. Estep and UPEP also were normal. So right now, we think he has amyloidosis, although there could be other infiltrative cardiomyopathies that he has. And it doesn't look like, at least in initial testing, that he has systemic amyloidosis, so we're thinking transthyretin amyloidosis. And so the question is, do we need a tissue biopsy for the diagnosis of this disorder? So if you had answered this question a few years ago, you probably would have said true, but in the modern era, this is less true. So this is a paper that came out a few years ago, and this is looking at an old technique. This is the technetium pyrophosphate nuclear scan, and what it does is it looks at the uptake in the heart versus the mediastinum. And for reasons that are not exactly clear, amyloidosis, the TTR amyloidosis in particular, will have an uptake in the heart 1.5 times what the mediastinal uptake will be. So you see in the top panel, let's see if we can go back a slide. So in the top panel, you see the heart versus the mediastinum are pretty equivalent. In the bottom panel, you can clearly see that there's uptake in the heart relative to the mediastinum. And if you look at the distinguishing this in patients that have known AL or TTR amyloid by biopsy, it's highly sensitive and highly specific for transthyretin amyloidosis. So there's two main types of amyloidosis that affect the heart, or that cause well over 95% of cardiac amyloidosis. One is the systemic AL amyloidosis, which is a plasma cell dyscrasia with elevated light chains, and TTR, which is transthyretin, which is a precursor protein made in the liver that can predominantly affect the heart and or the nervous system. For AL amyloidosis screening, as I mentioned before, the free light chain assay is a really extremely helpful first test that we can get. And the reference range you see here between 0.26 and 1.6, but really studies have shown that if you use less than 0.5 or greater than 0.5, or greater than 5, that's highly accurate for diagnosing AL amyloidosis. And if you're suspicious for amyloidosis, but that ratio is in between 0.5 and 5, then that would increase your suspicion for the possibility of transthyretin or an alternate diagnosis. And also to consider other infiltrative cardiomyopathies such as hemochromatosis, which you would use these blood tests to help diagnose. But hemochromatosis typically will often have a dilated phenotype after many years. So the diagnostic algorithm for amyloid, and I would not portend that this is a one-way fits all patients, and there's actually several expert opinions with various diagrams that look very different from each other, and it's really, I think you have to take it on an individual basis, but this is one way by the Mayo Group, and if you're suspecting amyloidosis, and certainly these things would make you suspicious, then you would want to get a free light chain assay, plus or minus a Estep and UPEP, and echo. And echo can be very sensitive. We didn't talk about strain, but there's a strain can be very helpful in the diagnosis of amyloidosis. MRI is also wonderful, but it's not absolutely necessary in all cases if you're highly suspicious and you have other tests that are positive. So if you have a positive Estep or UPEP, you would then go on to a bone marrow biopsy. That's why in the question I asked before, I wouldn't go straight to a bone marrow biopsy, because if you order these tests and they're negative, then you'd be more suspicious for transthyretin amyloidosis, in which case you can order the technetium pyrophosphate, if that's, and along with blood for genetic sequencing. And if they have transthyretin amyloidosis, they can either have a genetic type or what we call the senile or wild type that's more common in the elderly. If you do have a bone marrow positive, then you've confirmed the diagnosis. If the bone marrow is negative and you're still suspicious for systemic amyloid, then frequently we would do a heart biopsy as the next step. So transthyretin, there's two distinct forms of transthyretin amyloidosis. One is the mutation type, the genetic type, and the other is the senile or wild type, as I mentioned. The symptoms of hereditary TTR range really from primary neurological to primary cardiac and largely depend on the specific mutation. But we should be aware that one mutation that is very common, it's present in 3 to 4% of African Americans, is the Val122 isoleucine mutation. The penetrance is not complete, so not everyone that carries this mutation will develop the disease. And we are recognizing increasingly that, especially with this technetium pyrophosphate technology that allows us to make the diagnosis in the absence of biopsy, you don't want to biopsy every 80 or 90-year-old that comes in with suspicion for amyloid, that we're recognizing patients with HFpEF and patients that are sent for TAVR with severe AS. There's a large minority of those patients that end up having amyloidosis. So for AL amyloidosis, new chemotherapies have had a dramatic improvement in survival, particularly the proteasome inhibitors. This was recently published in JACC, showing that patients that are on proteasome inhibitors can have a better survival than patients that are not. And then carefully selected patients can undergo chemotherapy, followed by heart transplant, followed by bone marrow transplant. 6 to 12 months later. And we have had some degree of success with that. At our institution, we have now done 22 patients with amyloid. Prior to the proteasome inhibitors and stem cell therapies, if you had amyloid in your heart, you really had a 6-month median survival, and that's changed dramatically in the modern era. So we've done 22. 5 of these have been TTR amyloidosis, and the rest have been systemic AL amyloidosis. We have a strategy of a delay. Most programs will do stem cell transplant at 6 months. We've delayed, with new chemotherapies, we've been able to delay that to about a year. And so right now, if you look at all our patients that have undergone heart or heart multi-organ, excluding the 2 heart-lung patients, we have a 1-year survival of 88% and a 5-year survival of those that have been out for 5 years of 78%, which is really not statistically different from our larger transplant population. So these patients, which usually we sent home for hospice and just several years ago, now are really able to have better outcomes. And this is a select group that's able to undergo transplant, but even with proteasome inhibitors, there's a lot more that are able to avoid transplant and to live for several years. So moving on to case 2, this is a 44-year-old Caucasian female with no past medical history who presented to the ER with 2 episodes of syncope in a week. The first episode, she saw her doctor and supposedly had a normal EKG. She's been tired and weak for 6 months. She denies any orthopnea, PND, et cetera. She had an echo that was normal, a non-invasive stress test that was normal. Her heart rate is 43. And then I do want to point out that Dr. Arvind Bhimaraj, a colleague who's really shared a lot of these slides on this last patient, and it was taking care of this patient. It's a great case that was too good to pass up. So this is her EKG, and so you can see P waves that march out without any relation to the QRSs. So she was found to be in complete heart block. Echo really, just at first glance, is pretty unremarkable. It looks like a preserved ejection fraction, normal size. But because of the advanced AV block, she underwent an MRI. And you can see in the MRI, this is the delayed gadolinium enhancement in the LV lateral wall, also in the RV free wall and apex, and it is non-transmural, so a non-coronary disease distribution. And they noted on the MRI that she had basal thinning of her anteroseptal wall, which is highly associated with sarcoidosis. And because of these features, they were very concerned that this patient appropriately had sarcoidosis. So what are the indications for a myocardial biopsy? It depends where you are. If you're, as we discussed, at Hopkins, there's pretty much you're getting a myocardial biopsy if you have heart failure. But if you have really what the guidelines recommend, and this is an expert consensus, not based on a lot of data, but if you have new heart failure less than 2 weeks and it's associated with a normal-sized or dilated ventricle and you have hemodynamic compromise, it's a class 1. If you have new onset heart failure, 2 weeks to 3 months duration with a dilated LV, new ventricular arrhythmias or advanced heart block, or failure to respond to usual care, those are 1A indications. Otherwise, related to our patient, unexplained restrictive cardiomyopathy is another indication for myocardial biopsy. So typically we do a myocardial biopsy through the RV. We get biopsies of the RV septum. We try to avoid the RV free wall so that we don't have perforation and tamponade. And we rarely get biopsies outside of the RV septum. So we did a biopsy of the RV septum, and not surprisingly, it was unremarkable. It was a negative study. And why is that? So there's really, for sarcoidosis and other diseases such as lymphocytic myocarditis, biopsies are very poorly sensitive. For sarcoid, a biopsy is notoriously bad at making the diagnosis, about 25% sensitive according to some studies. And the reason is because it's patchy involvement. And you saw in the MRI there was scar in the LV lateral wall, the RV free wall, but there was not really scar in the RV septum, which is where we're doing the biopsy. So she came back, she had another AICD shock. There was no real mediastinal lymphadenopathy to biopsy. So the next step was something that we discussed, which should we try empiric steroids? Should we send her for VT ablation, or should we consider biopsying the LV where there was more scar? So what in conversations with Dr. Bhimaraj and Dr. Valderrabano, our electrophysiologist who has a lot of experience with these robotic catheters for his EP ablations, we decided to do a robotic-assisted biopsy of the LV. So this is the robotic steering guide, and as you can see, as opposed to the biopsy that we have normally, we manipulate with our hands, we move it one way or the other, but we're not able to achieve this degree of targeted biopsy that you can have with this robotic system. So this the catheter is controlled outside with our electrophysiologist using the robot to steer the catheter where we want it, and then we can put the biopsy catheter through the steering catheter. So this is the system, and then we use really what's been shown in a handful of case series and case reports is to target biopsies. You can use what's called an electrical mapping system, where you can map out the voltages so that areas that have low voltage across it usually have scar or inflammation, and they don't have the same electric potential across it, and that's areas that you can target for your biopsy. So this was done in the cath lab. You can see the robotic guide with the biotome inside. Here's the biotome jaws opening up and grabbing a bite on the LV lateral wall where you saw the scarring. This is intracardiac echo, where you can see this white dense thing is the steering catheter. You can see it taking a part of the ventricle there. And then again, in the LV outflow tract, you can see, so this is crossing, I should mention, this is venous, crossing the septum, going into the LV. And we can, if we were going to biopsy this from a different approach, if we wanted to do an LV biopsy, we'd have to go arterial stick and do this in the LV with heparinization. But so this patient had a biopsy in the LV outflow tract as well. And you can see that while this was negative in the free wall, the outflow tract was positive for sarcoidosis, as we suspected. You can see the presence of non-causating granulomas and multinucleated giant cells, which are common in sarcoidosis. So the diagnosis of sarcoidosis, there's really no true gold standard, although histology is diagnostic. The Japanese Ministry of Health and the Heart Rhythm Society have both created diagnostic criteria. Cardiac MRI and PET scan are increasingly used. There's really no comparative diagnostic accuracy data, partly due to the lack of a true gold standard. A lot of the studies have used the Japanese Ministry of Health criteria as the gold standard, which has its limitations. But so histological diagnosis really should be attempted if it can. And this is a nice slide from Holton et al. Showing the complementary effects of MRI and PET scan. You can see here on the MRI, you do see some scarring here in basally, and you can pick that up on the PET scan, but the PET scan also will pick up some areas of inflammation that are not noted by MRI. So they really can play complementary roles. Unfortunately, we didn't have a PET scan in our patient. And then just to briefly, not to go through this all, but to show you the different clinical criteria. This is the Japanese Ministry of Health criteria that was updated in 2006 versus the Heart Rhythm Society from more recently. And they either have histological diagnosis, and if you don't, then clinical diagnosis with major and minor criteria, depending on the degree of AV block and MRI, et cetera. The one criticism of the Japanese data is they're still using positive gallium uptake in the heart. We rarely perform that. MRI and PET scan have really been shown to be better tests for this disorder. And then for the final question, so all the following are recommended therapies for cardiac sarcoidosis according to the most recent society guidelines. So except which one? So prednisone, methotrexate, ACE inhibitors, ivabradine, we've heard a lot about today, beta blockers. You have 1 minute and 15 seconds to vote. Yeah, so 71%, 67% of you are right. So really for the treatment, steroids and steroid-sparing agents such as methotrexate are used. There's not a lot of good randomized data, but we use prednisone usually. Start them off at doses around 60 milligrams and taper off, and then add steroid-sparing agents. And then typical ACE inhibitors, beta blockers are also used, especially for the antiarrhythmic effect if they're not in heart block, such as our patient. And that is my last slide. Thank you very much for your attention.